Muted.
Hello everyone and welcome. This is Annabeth Brown with the North Carolina Learning Collective, and Happy New Year. This is the start of our lunchtime webinar series, and I see a number of you have signed on. If you have any difficulties during the webinar, please feel free to use the chat box. I'll be monitoring that, and we'll try to work out any technical issues. I understand that people can hear and can see the screen, so that's great. It is my pleasure to introduce Donna Cohen, whom I have gotten to know through this North Carolina Learning Collective, and she's a fabulous partner. She's also an expert in population health. She's a task lead in population health for Alliant Quality, and she works with practices in North Carolina on reporting quality. So we're very fortunate to have her do our inaugural webinar today, and with that I will turn it over to Donna.
Thank you, Annabeth. I appreciate it. It's my pleasure to be with you all today. As Annabeth indicated, I work for Alliant Quality. We are the quality improvement organization in North Carolina. So we are funded by CMS to assist physician practices in reporting quality data. I have listed my email address along with my contact information. So after the presentation, if you have any follow-up questions and you would like to chat individually, please don't hesitate to reach out to me, and we can discuss how Alliant Quality may be able to assist you in reporting your quality measures. With that, Annabeth, if we can advance to the next slide, please. Today, we're going to understand why insurers are moving toward value-based payments. Why, as a country, we are shifting from volume to value with the payments that we are reimbursing healthcare facilities and providing care to our Medicare beneficiaries. We're going to understand how experience with the current value payment programs will prepare you for future changes that will be coming in the coming years. We're also going to understand what MACRA is and how to prepare for MIPS. The main portion of our seminar today will be talking about MIPS because most physicians will be falling under MIPS, which is the Merit Incentive Payment System part of MACRA. And then last, we're going to understand some steps that you can take now to prepare you for these changes in payments beginning in 2017. Next slide, please. So why move to value? Why are we talking about changing the payment structure? This is a very busy slide, but the point I want to make here is if you look at 11 countries across the world and compare the quality of care that we provide here in the U.S. with those 11 different countries, and in looking at quality of care, access to care, efficiency, equality, as well as healthy lives, the U.S. ranks 11. Compared to these other 11 countries that you see here on the screen in terms of quality. And if you look at health expenditures, even though we're 11th in quality, we rank sometimes 2 to 3 times higher than our other countries who are providing much better quality of care to the patients that they serve. When I talk about quality of care, I'm not talking about specific cancer treatment. or cardiovascular surgery. We know we do a great job. This slide depicts overall care, so access to care, immunization rate, infant mortality, everything associated with the care of the entire population. Next slide, please. So you think, okay, we're spending all this money, then we should be living longer, right? But if you look at the life expectancy of the U.S. compared to these other countries who spend much more money or who spend much less money on health care, you see that our average lifespan, the numbers from 70 to 85 on the left-hand side of the screen, you see that we don't do so well as far as life expectancy, even though we're spending 2 to 3 times more money. Next slide, please. So as I indicated, we're going to spend much of the morning or afternoon talking about MIPS, but I would be remiss if I didn't take just a minute to talk about 2016 reporting. So for quality reporting for 2016, that now is the time to be thinking about reporting for 2016 if you have not done that. Hopefully all of you have already done that. But basically what MIPS does, again, Merit Incentive Payment System, is it takes our current 3 systems, PQRS, value modifier, which is the cost portion, as well as meaningful use, which is that EHR component, and combines it into one program. In 2016, is our performance period, and the PQRS payments is always a 2-year lag, so 2018 payments will be reflection on this year. So if you have not thought about how you're going to report PQRS or meaningful use for 2016, make sure you give me a call and we can talk about how you can successfully do that. And then we can roll all that into 2017 and the changes in reporting for 2017. Next slide, please. So traditionally, we have worked under a volume-based payment system. The more patients that I see, the more money that I receive from Medicare, regardless of the value that I'm providing to those patients that I'm giving care to. In 1997, Medicare established the sustainable growth rate because Medicare realized that overall physician cost was going up and it was greater than our targeted Medicare expenditure, so we could not continue this way. So each year Medicare would pass temporary doc fixes to avert cuts that were going to happen in Medicare. In 2015, if these doc fixes were not passed, then Medicare payments would have suffered a 21% cut. So CMS said, you know, we've got to do a permanent fix. We can't just worry about this every year and try to put a temporary fix on this. Next slide. So in 2017, the Quality Payment Program has begun, January 1st officially, and the Quality Payment Program is called MACRA. It will be serving 55 million Americans on Medicare, and it is the first major step that Medicare has embarked upon to really change the way that we are reimbursing providers for the care that they give. It is the first year, and there will be changes as MACRA evolves over time. So today's presentation is based off of the laws as we know it today. Next slide. So the performance period for the Quality Payment Program begins, as I said, January 1st, 2017, and it ends December 31st, 2017. There is a flexible start date for data collection. There were a lot of providers who sent in concerns to Medicare over the past year about not being able to participate successfully in the Quality Payment Program, mostly around the lack of electronic health records. So CMS listened and they said, okay, we will have a flexible start date anytime between January and October. you can report your data, with the final submission of performance data due by January 31st, 2018. Next slide, please. So the Merit Incentive Payment Program, MIPS, which again we're going to spend most of our time talking about today, will affect most of the physicians in the state of North Carolina. If you do not participate in MIPS, then you would be participating in an Advanced Alternative Payment Model, APMs. Most APMs, or all APMs, requires providers to take financial risk for taking care of a certain population. There are not a lot of APMs that exist currently today in our southern states. There are a good number of APMs in the northern states, and we expect APMs to continue to grow over time. But the majority of physicians in North Carolina will be participating in MIPS, which is the Merit-Based Incentive Payment Program. And this will allow physicians to earn bonuses through participation in the MIPS program in 2017 and moving forward. Next slide, please. There are a group of physicians who are excluded from MIPS. If you are a clinician who has never accepted Medicare, this is your first year of accepting Medicare patients, then you are excluded from MIPS during the reporting period. If you are a clinician who has a low volume threshold for Medicare Part B allowable charges, and that is less than or equal to $30,000, or you have 100 or fewer Medicare Part B patients, you are excluded from MIPS. If you are participating in an advanced alternative payment model, which I talked briefly about just a moment ago, then you are excluded from MIPS. So those are the three criteria of physicians or eligible providers who would not be included in participating in MIPS. Next slide, please. So as I indicated, CMS listened to the feedback from providers and came back in about October, early October. It said, you know, we're going to let providers for the first year of MIPS pick their own pace. If they do not participate at all, then you will receive a negative 4% payment adjustment. But if you submit something, if you submit one quality measure or you submit one improvement activity, this will avoid the negative payment adjustment. So that's all you have to do for 2017 to avoid the payment, the negative payment adjustment. Or if you have been reporting PQRS and maybe you've been reporting testing for meaningful use and you're familiar with it, then you can submit 90 days of data and you will earn a neutral or maybe a possibility of a small positive payment adjustment. Or if you've been very successful in the past in submitting PQRS data, your QRUR, which we'll talk about more in detail, your cost is low and your quality is high, then you may want to go ahead, or I would strongly suggest you go ahead and submit a full year of data because you can earn a moderate positive payment adjustment. We don't know exactly how much that is. It really depends on how many physicians submit a full year of data because there is a bucket of money which will be divided. So the more physicians that submit a full year, the less the pot of money will be because it will be distributed according to quality and value. Next slide, please. So if we take a deeper dive here and we look at 2017 being the performance year, you will submit your data March the 31st of 2018, no matter what way you choose to submit. As most of you know now, depending on the methodology that you use to submit your PQRS data, the due date for the submission can change. But this consolidates everything and all the data will be submitted on March the 31st of 2018. Then providers will have a feedback report available to them, and then in January the 1st of 2019, your payment adjustments will begin for your 2017 performance year. Next slide, please. So what will those adjustments actually be? As I indicated before, for 2019, it could be a negative to positive 4% adjustment. And then in 2020, that goes up to a negative to a positive 5. And then by 2022, you would have a negative to a positive 9% adjustment if you are participating in MIPS. If you're participating in an advanced alternative payment plan model, then you are subject to a 5% bonus across the board beginning in 2019. Next slide, please. So let's take just a moment to talk about an alternative payment model. It is a payment approach developed to really provide incentives to physicians who are providing high quality and cost-efficient care. The alternative payment models can apply to specific clinical conditions like diabetes, a certain episode of care like an OB delivery or hip replacement, or a certain population of people. Alternative payment models offer significant opportunities for eligible clinicians who have not been able to participate or prepared to take an additional risk or requirements of an advanced alternative payment model. So there are advanced payment models and advanced alternative payment models, which is a subset of the advanced APM. Next slide, please. You see on the slide in front of you in 2017 some models for the advanced alternative payment models. As I indicated, most of these or none of these are really available in the state of North Carolina. So all of the physicians in your area will be participating in MIPS in 2017 if they choose to participate in the quality payment program for Medicare. Next slide, please. So who do we think will be participating in MIPS? It will be about 600 clinicians will be eligible to participate in MIPS or an alternative payment model in the first program year. As I indicated, a negative to a positive 4%. That will increase to a 9% in 2022. And it replaces up to 9% of the penalties that physicians would have acquired if we were still in the legacy program, which is meaningful use, PQRS, and your value-based payment modifier. Next slide, please. So if we take just a moment and look and compare the legacy program to the scoring that will be affected by all of you under MIPS. In 2016, we reported PQRS. If we did not, the payments adjustments could be a negative to a positive 2 to 4%, depending on the size of your practice. For meaningful use, if you were not attesting for meaningful use, then you had a possibility for a negative 5% adjustment. And then on your value modifier, which is based off of cost and quality combination, a negative 4%. So you were, if you didn't participate in any of these programs in 2016, your total penalty risk was a negative 11%. So if we look at the scoring for 2019 adjustments, we see that there's only a total penalty risk of negative 4%. So CMS is really giving providers an opportunity to adjust to the new payment system and really work with them on making sure that they are successfully reporting quality measures, advancing care information, resource use, and these improvement activities, which we'll talk about more in detail. And if you are a very high performer and you report for the entire year, you have a potential for a 10% increase for those high-performing offices. So again, if you are one of those practices who has been very successful in reporting PQRS and meaningful use, and your value modifier is reflecting high quality and low cost, then I would certainly suggest that you get in competition for that 10% bonus for the high performers. Next slide, please. So the 4 performance categories in MIPS is quality, which in our legacy program was PQRS, advancing care information in our legacy program, which was meaningful use, cost, which in our legacy program was the value modifier, and there is a 4th component of MIPS, which is clinical improvement activities. This is a new category, and we'll spend a little bit of time talking about what these improvement activities are and how you attest for those improvement activities. Next slide, please. If we look at how your score is weighted, in 2017 performance, which again will be reflected in your 2019 payment, 60% will be based off of quality. 60% of your overall score of 100 points will be based off of quality. 25% will be based off of advancing care information, and 15% will be based off of those improvement activities. In 2017, cost will not be a factor. Again, this was a change that occurred in around October of 2016 to the initial proposal. Cost will be a factor moving forward, but in 2016, cost will not be part of your scoring for your MIPS performance. Next slide, please. When we're fully transitioned into MIPS, the law requires that 30% of your overall score will be based off of quality, 25% would be based off of advancing clinical information, which is that EHR component, 15% improvement activities, and 30% cost or your value modifier. Next slide, please. So who will be eligible to participate in MIPS? In December, CMS told us that they would be contacting all clinicians to let them know that they were eligible to participate in MIPS. And sometime this month, we anticipate CMS to release an NPI lookup tool on the quality payment portal, which we will talk about more in detail, to let physicians know whether or not they are eligible to participate in MIPS for 2017. Next slide, please. So there is an excellent website on the quality payment program at qpp.cms.gov. Annabeth, if you could just type that maybe into the chat so people can copy and paste that into their browser and save it as their favorite. This is a great resource. If you're familiar with CMS's website, you will be pleasantly surprised by how well laid out this particular website is. CMS spent a great deal of research and did a lot of beta testing with different providers to make this website very user-friendly. So I encourage you to go onto the website. It will help you choose measures. You can learn more specifics about the programs, and there's a lot of educational tools and resources on this website that I think you'll find very useful. Next slide, please. So let's take a little deeper dive into quality. As I indicated, it's going to count 60% of your overall score. For 2017, you only have to report 6 quality measures and include an outcome measure for a minimum of 90 days. Now remember, this is if you're reporting for the full year. If you're one of those providers who's never reported before, you can successfully report in 2017 only by reporting 1 quality measure. But to participate in full macro participation for 2017, you want to report 6 quality measures. Groups who use a web interface to report will report 15 quality measures for the full year. And groups in alternative payment model qualifying for special scoring under MEP, such as the shared saving programs, will report quality measures through their APM. So if you're participating in an APM, then you will report your quality measures through the APM. There are 271 quality measures available for you to report. Next slide, please. There are also selected specialty measure sets. In 2017, the measure set for specialty providers has really expanded. So if you are one of these specialties listed on the screen, there will be specialty measure sets specifically for you. I know in the past, for some of the specialists out there, they've had a hard time reporting quality measures, especially using some of the measure sets that existed. But you see on the screen now that that has really been expanded. So our specialty care providers, I think, will be very excited about these new measure set categories that they will have to choose from in reporting quality measures for 2017. Next slide, please. So how are you going to report these quality measures that are 60% of your score in 2017? If you're an individual clinician, you can report through a qualified registry, through an electronic health record, through a qualified clinical data registry, or through claims, just the same way as you can report PQRS data today. If you are a group, again, same method that you are using for 2016. You can report through the qualified registry, through your EHR, through your qualified clinical data registry, or through the CMS web interface if you are a group with 25 or more providers. And you have to report patient satisfaction or CCAPs for your MIP survey if you're reporting as a group. Next slide, please. So clinicians will receive 3 to 10 points for each quality measure based on performance against benchmarks. So physicians will be benchmarked with others in their area, in their specialty, to determine how many points they will receive for their quality. If you do not submit any performance data under quality, then you will have 0 points under this quality measure. Next slide, please. So I mentioned the QRUR. That is the Quality Resource Use Report. And this takes your PQRS data as well as your cost data, which comes through the claims that you submit, and you are benchmarked, again, against your peer to determine if you are a high-quality, low-cost provider, which is where everyone should strive to be, or whether you're in that quadrant of low quality and high cost, which is not where you want to be. So your QRUR basically divides your measure into 2 measures, the Medicare spending per beneficiary, and this measure is around resource use or cost from 3 days prior to a hospital admission to 30 days after discharge. And then the per capita cost for all attributed beneficiaries. And this number represents the average cost of all Medicare Part A and B, so your physician office as well as your hospital payments, to providers for beneficiaries attributed to that particular 10. So the primary care physician that is attributed to providing most of the primary care services to that particular patient would be assigned that beneficiary in their QRUR report. Next slide, please. Improvement activities must be performed for 90 consecutive days. You would attest for these improvement activities that you are working on during the reporting period. And again, this can be reported through the same methodology that you're using to report your quality data, which is a qualified registry, your EHR, or your qualified clinical data registry. And if you're reporting as a group, you can report through the CMS web interface. Next slide, please. So on the screen here, you see a list of several of the 93 possible improvement activities that you can do to satisfy this measure under MIPS. The ones that I have highlighted in red are services that we offer through Alliant Quality that we can assist you with in fulfilling the requirements of these clinical activity improvements. Things like, are you offering, are you asking patients if they are using tobacco, and if so, are you counseling? Are you screening patients for alcohol use? We also have a program with antibiotic stewardship to make sure we're not overusing antibiotics, depression screening, any of these clinical improvement activities. But also, if part of the improvement activities are things like access to care. So do patients have access to speak to someone to get care? And this can be an answering service. It doesn't have to be your office, to try to prevent those patients from just showing up in the emergency room when they probably could have be seen in the physician office the next day. So really looking at how we can lower costs by making sure the patient's getting the right care at the right place at the right time. Next slide, please. The good news is if you are participating in a patient-centered medical home, then you will receive 100% of the value of these improvement activities by participating in a patient-centered medical home. So it has to be a certified patient-centered medical home that you are working with. And again, you will get 100% of participation or credit for this improvement activity if you are a patient-centered medical home. Next slide, please. Next slide, please. If we look at the advancing care information, which again is the meaningful use part of the quality payment program, it enables physicians or eligible clinicians to report as individuals or to report as a group. In the past, when you were testing for meaningful use, it was always at the individual level. However, with MIPS and the advancing care information process, this has changed, so you can attest as a group instead of individual. It allows for data submission beyond the attestation as we've known it in the past. You can submit data through the registry, through your EHR, or through qualified clinical data registries. It requires clinicians to implement a certified electronic health record in good faith, and that you will make sure that you are not blocking access and not interfering with sharing that clinical information between electronic health records. MIPS does not impact Medicaid meaningful use, so you still will be able to participate in Medicaid meaningful use, nor does it impact hospital meaningful use programs. Next slide, please. Clinicians are required to report data for the full calendar year. It does align with the other reporting requirements of your quality along with your clinical improvement activities. The first performance year is January 1st, and again, it ends in December the 31st. To successfully attest for advancing care information in 2017, you need to utilize the most current version of the 2015 version of a certified electronic health record by 2018. In 2017, you still can use the 2014 edition and submit modified measures. If you are currently at stage 2 meaningful use, then you should be good with the 2017 requirements of advancing care information. And remember, in 2017, it's a transition year, so if you don't have an EHR currently, and you report one clinical quality measure, or you report one clinical improvement activity, then you successfully meet the requirements for reporting MIPS in 2017. Next slide, please. You have two measure set options available for you for reporting in 2017. Option 1 is Advancing Care Information Objectives and Measures, which is 15 measures. And then option 2 is Transition Objective and Measures, which would be 11 measures for you to report. And you can choose either option that you want to choose in reporting Advancing Care Information for 2017 if you choose to report on this measure in 2017. Next slide, please. I spoke a little bit about the QR-UR report. For those of you who have accessed that report and reviewed it, I commend you. For those of you who have not, I would encourage you to go out to the CMS portal and look at your QR-UR report. It will require that you have an EIDM account to access this report. And again, if you need help with that, please contact me and I can certainly walk you through the steps in setting that up so you can pull this data. It will help drive where you are now in terms of quality and cost and really help you develop a project plan for where you need to go to be able to fall in that higher quadrant of, or that optimal quadrant of high quality and low cost compared to your peers. Next slide, please. Can you back up one slide, Annabeth? So now we will ask Annabeth to review any questions that have been placed in chat. Again, my contact information as well as my email address is here. If you want to shoot me an email, you can certainly do that as well. So Annabeth, do we have any questions in chat?
We do have a couple questions. Donna, thank you so much. That was great. We're a little bit over our time. Do you have time to answer a couple of questions?
I do, for those who want to stay on.
Great. I just have a couple.
We'll do about 3 minutes.
Okay. One question that I got a couple of times is, will your slides be available? We are recording and we'll archive this webinar on the Start With Your Heart website, but I think people want your slides. Is that a possibility?
Anna, Beth, if we have captured everybody's email address, when we get that information, then I will forward my slides to those people who listed their email address in this presentation. I will also post it on the alliantquality.org website. I will, there are already several presentations out there on MIPS and MACRA, so I encourage you all to go to the alliantquality.org website and look at the information that is already out there. This particular presentation is not there yet, but there are many other presentations that contain the same information that's already posted there. So thank you.
Thank you. I had a couple of questions. One is, please explain CMS web-based reporting.
So CMS web-based reporting is where you actually log on to the portal and to the CMS portal, and you as a provider report your data directly to CMS versus having a third-party vendor do that.
Great, thanks. And what types of providers are eligible?
For MIPS, there
yes.
For MIPS, so physicians, mid-levels, which include nurse practitioners, PAs, and I can send a list out when I send the presentation because I'm blanking on all of them now, but I will send the list out of eligible providers when I send the presentation out to everyone.
Great, thank you. And is the NPI lookup tool available now?
It is not available currently. We expect it to be released any day.
Okay, and those are all the questions that I have at this point. Donna, I want to thank you so very much, and I want to thank everybody who called in. We've had great response on this. If you have follow-up questions or concerns, please ask Donna your questions or let me know if you need more information. I want to invite everyone to tune in February on the 14th, actually. It'll be on Valentine's Day at noon, for a webinar on tobacco cessation resources and a report on e-cigarettes and vaping, which is on the increase. So that should be very interesting. So thank you very much, everyone, for tuning in, and we want to thank Donna Cohen especially for a wonderful presentation. And you guys, please be in touch. Let us know any feedback that you have about today's webinar, and thank you very much.